All right, here we go. Hello, everyone. My name is Dr. Marty Kotler. Thank you for attending this webinar on billing and coding for knee injections, trigger point injections, knee braces, PRP, stem cell. Just a little disclaimer before we get going. The information in this presentation is for educational purposes. It's not intended to be a substitute for your thorough clinical decision making. It's not intended to be a substitute for your billing protocols. It's not intended to be legal advice. Target coding doesn't provide legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Now, we have a lot of people listening to this presentation. I wasn't expecting this big of a turnout. So we have a lot of people listening to this webinar. Uh, some of you listening to this are members of Target Coding. Some of you are just past attendees of our seminars and webinars. And some of you have no idea who I am. So let me tell you a little bit about myself. Again, my name is Dr. Marty Kotler. I'm a chiropractor, and I practiced for 16 years prior to starting my company, Target Coding. My first 12 years were chiro only, and then last 4 years are integrated. I'm a certified professional compliance officer, certified billing and coding specialist, and my company has been helping thousands of chiropractors and integrated practices and their staff members for over 14 years now. Now, some people say, oh, I'm the insurance guy. I am not the insurance guy. You want to put a label on my head? Call me the compliance guy because our specialty is in compliance as it relates to coding, documentation, cash plans, Medicare, HIPAA. 30% of the doctors we work with are cash practices. Yes, I said cash practices. Many cash practices need assistance with the types of prepay plans and discount plans and financial report of findings being done properly. And in some states, there are limits on the amount of prepay money you can take. Do you have to put the money in escrow? All that stuff. Yeah, compliance as it relates to cash. I've written many training manuals on billing and coding and documentation for chiropractors, physical therapists, and nurse practitioners. I'm a contributing writer and author to many publications and magazines that you see coming across your desk, like Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor. I write newsletters for many state associations across the country and other related organizations in the industry providing newsletters and good quality information. I'm a guest speaker at numerous chiropractic conferences nationwide. And I consider myself kind of unique. Why? Because most chiropractors are not certified in coding, and most certified coders are not chiropractors. I'm both. And you'll see during this webinar how I combine both specialties to make sure you're doing things properly, you're complying with all your local, state laws, state, local, and federal laws and rules, and you're getting reimbursed what you deserve, right? You should get paid for everything you do. It's amazing how many staff members and office managers I speak to who don't give me the impression that they're trying to get the doctor paid for everything he or she does. That's my goal. I want to see my clients getting paid for everything they do. Why? Because they deserve to get paid for everything they do. And I'm going to show you how to do it in this webinar. What are we going to do? We're going to start with a brand new patient. Let's start with a brand new patient that's coming in with knee pain. All right, here we go. New patient calls to make appointment. Your CAs should be trained to ask the patient, are you calling to see our medical doctor for a knee injection? Are you calling for chiropractic care? Are you calling for physical therapy? This is a great practice building tool because some patients may not know that you're doing other services. You may be an existing chiropractic practice for the last 12 years, and now you just became integrated. You're going to have hundreds, maybe thousands of patients that know you as a chiropractic office, and they may refer a friend. And then that friend calls for chiropractic, thinking you're only a chiropractic practice. Train your staff. We do this all the time in our CA boot camps. Train your CAs how to plant the seed on the very first phone call that you do more than chiropractic. Staff members go through all your normal new patient questions. Now the new patient arrives and starts to fill out your forms. Now, it would be nice if you can get the patient to log into your patient portal. That's what most of our clients are doing now, getting rid of all the paper. Patient makes an appointment, patient is sent an email, the patient logs into the doctor's patient portal, creates a username and password, and now is filling out all the information on all your forms. Yeah, forms. We got to get the forms out of the way. Have the patient fill out online before they even come into the office your new patient health history form, HIPAA notice, financial forms, authorization to release information and pay, consent to treat, informed consent, consent to treat minor. If you're treating Medicare patients, maybe you need to have them sign an ABN form right on day one. Stem cell, PRP, there are certain services that are just totally not covered by insurance. It's a good idea to have your Medicare Part B patients sign an ABN form, insurance non-payable services form, letter of protection. By the way, we sell a forms packet. We have all these forms. Members of Target Coding, you know, you all get these forms. Our level 3 members get all of our forms. We have over 100 forms in Microsoft Word ready to go. If you're not a member, that's okay. You can purchase them. Just go to our website. They're for sale. We could instantly email them to you. Get good quality forms, HIPAA forms, notice of privacy practices. These protect you more than the patient. Patient flow. Who's going to see the patient first? Does the medical doctor, nurse practitioner? Again, we're focusing on integrated practices. We're focusing on chiropractic offices or medical offices that are now thinking about or are presently doing knee joint injections. So you should create a good quality care plan, treatment plan, plan of care. It should consist of these 6 things. Now, your medical doctor or nurse practitioner is the quarterback and responsible for all procedures and recommendations. The MD or the nurse practitioner must reevaluate the patients on an ongoing basis. Recommendations should be made clear in the notes and have clinical justification. Everybody needs to know what everybody else is doing. One of the biggest problems in an integrated practice, and it happened in my practice, a lot of the things I'm sharing with you, I learned because I messed up. You're learning a lot of things today because of the mistakes I made. That's okay. I'm willing to do this for you. You know, you learn from mistakes. Some of the biggest successes I've had in my life were made from mistakes that I made. So mistakes aren't necessarily a bad thing. So I'm going to share with you the mistakes. Some of the mistakes in an integrated practice is the right hand doesn't know what the left hand is doing. Medical doctor's doing something on a patient and the chiropractor's doing something on the same patient, and there's no communication. And now there's weird stuff going on. For example, the medical doctor's billing out with subluxation diagnosis codes. Come on, can't do that. So good quality history as of the new guidelines as of January 1st, and this is something that most of the nurse practitioners that we train have no idea about the new guidelines that became effective on January 1st of this year. Chief complaint, history of present illness, good basic history. Review of systems. This is not an exam. Review of systems are a series of questions seeking to identify signs or symptoms which the patient may have experienced in the past or are presently experiencing. Your nurse practitioners should be doing a good quality past family social history. Now, some of the offices we work with, yes, there's a nurse practitioner on site, but the chiropractor is doing the initial schmoozing. The chiropractor is not working in the role of a chiropractor. Now, there's all different types of models out there. Those of you familiar with integrated practices, you know there's tons of companies out there. There's one in California, one in Georgia, one in Minnesota. There's about 7 or 8 practice management companies that preach bringing on a nurse practitioner. And they all have different models and approaches, which is great. If you're a client of theirs, just listen to what they're doing. The problem that I see with many of them is they don't have a certified coder on staff giving you specific information on codes and supervision levels. For example, I see a lot of integrated practices where the nurse practitioner is overseeing physical therapy, and the physical therapy is done by Sally, who's who was a teacher last week, or Mary, who was a cashier in Walmart, or you have maybe a PTA doing it on billing Medicare Part B. Can't do that. Careful with the recommendations you receive from practice management consultants on billing and coding. That's why I stay in my lane. I'm not a practice management consultant. I'm not going to tell you how to get new patients or teach your CAs how to, get new patients or how to do a report of findings or how to put together a 90 visit care plan. We don't do that. Stay in our lane. Examination. Your nurse practitioner is now, or medical doctor is going to do an exam for a potential patient that needs a knee injection. Get trained. Here's just a quick glimpse of our knee exam. Test those quadriceps, hamstrings, biceps, femoris, gastrocnemius, gracilis, all the major muscles of the knee. Test all of them. Test both sides for strength, posture, general appearance. So make sure that your nurse practitioner, medical doctor, physician assistant, osteopath does a good quality exam. They're going to be doing maybe trigger point injections in the upper back, upper thoracic. Here are some of the major muscles in the cervical and the upper thoracic region, major muscles in the lower back. You're going to do a joint injections. You're going to do maybe stem cell into the lumbar region. Well, get good at these muscles, psoas, piriformis, get your nurse practitioner, medical doctor to learn how to test these muscles and check them for weakness. Many, many different types of exams that should be done by your nurse practitioner. And then, yeah, I mentioned these new guidelines as of January 1st. It's based on either time or decision making. The old guidelines, which were around for how long? 25 years? From 1995 through December 31st of 2020, we had these old, outdated guidelines. Those of you that have been to my seminars and webinars in the past, you remember how I would go through the history for 99203. What was that? You had to write down at least one chief complaint, 4 HPIs, 2 to 9 systems, right? A lot of you remember this. HBIs, PFSH, when it came to an exam, a 99203 exam, what did you have to do? 12 examination findings, not 11, 12, and then decision making. Well, as of January 1st of this year, forget about those guidelines, new guidelines based on time or decision making. Now, one of the things that got deleted was this code 99201. Bye-bye, no more 99201. So time, here are the time components for your new patient codes and your re-exam codes. The old guidelines for 99203, it was around 30 minutes. Well, right now, no more of that. If you jot down 29 minutes were spent, you can't bill at 203. So what's included with time? You should know the obvious, speaking to a patient, your exam, but there are a few things now that count towards time for your new patient codes and your re-exam codes. How about the time it takes you to document? It might take about 5 minutes to enter the patient's diagnosis, schedule of care, goals, services rendered. That counts. Reviewing records, MRI, CT scans, calling other doctors. Or you could use decision making. Now, I'm not going to get into too many details on this because I have a whole webinar just on this topic. But if you're going to bill for your nurse practitioner exams and re-exams with the new guidelines using decision making, well, if you're drinking coffee right now, take an extra sip. It gets complicated. It's based on these 3 elements. You see them on your screen. Element number 1, the amount of problems. And then there is examples there. For 99203, an example might be 2 or more self-limiting problems. What's an example of that? In our webinar, we go over that. What's an example of 1 acute uncomplicated injury? We go over that in the webinar. And then you go to the next column. There are 3 elements. The second column is the data to review. Does the patient bring in x-rays, MRIs? That can bring your E&M code up a notch. How about an independent historian? You see that in the middle column towards the bottom under category 2, under decision making for data to review. It says an assessment requiring an independent historian. What's an independent historian? Well, I'll show you in a second in the definitions. Well, I'll tell you right now, an independent historian is a person that's assisting with the history. For example, you have a 94-year-old patient come in with dementia. This person cannot explain what's going on with them. Well, this person would bring in a caregiver, an aide, maybe a child, a surrogate. What happens if you have a 4-month-old come in with colic or ear infections? This 4-month-old can't explain what's going on. So the parent, surrogate, guardian, they're acting as an independent historian. That can raise your level of E&M coding, and you only need 2 out of the 3 components for decision making. You don't need to have all 3. 2 of 3 elements for that level of decision making must be met or exceeded. So time, again, 30 to 44 minutes for 99203. Now you might be saying, well, isn't it possible to bill a 203 and spend less than 30 minutes? Of course, then you'll have to use decision making. The way we teach it with our clients, get strategic as far as billing for decision making versus time. We have some clients on all their PI patients, they're using decision making. On all their Blue Cross Blue Shield and United Healthcare patients, they're using time. On their cash patients, they're using time. All their Aetna patients, they're using decision making. Very important. You're running a business. You want your business to be maximizing reimbursement, I'm assuming. Step 1 is to treat the patients with good quality care. Step 2 is to maximize reimbursement. That's the order. That's what we teach. Step 1, patient care, always primary. It helps if you're ever audited in a malpractice case, being investigated. If you give the impression all you care is money, you're going to go down as being guilty and have to give money back or other probation and fines and penalties. I've seen it. Been doing this a long time. 12 years. I've seen just about everything. Actually, I saw something. A doctor recently, a patient tried to shake down the doctor, accusing the doctor of things and saying, if you don't give me money, I'm going to report you to the board. Wow, that was a first. All right, so new patient versus established patient hasn't changed. The rules are still the same. Now, some of you might be saying, Dr. Kotler, how did you get so smart? When I do my live seminars, a lot of CAs come up to me on the breaks and go, Dr. Kotler, how did you learn all this? Where do you get your information? So here, I'll share with you. And I read a lot. I read like a maniac. I'm telling you right now. I spend 20 to 30 hours a week reading stuff on billing and coding and medical policies. And these are my resources. This is my library. I spend $5,000 to $8,000 a year on medical books, auditors, training, consultants, list data, serves, knowledge bases. This is where I get my information. So 99% of the things I teach are right from these manuals. 1% is usually my opinion. Nurse practitioners, yeah, wonderful addition to a practice. If you're thinking about integrating, I think a nurse practitioner would be one of the first things you'd want to look into and start interviewing. There are approximately 270,000 nurse practitioners in the country, about 70,000 chiros. There are over 1 million medical doctors, 200,000 physical therapists, about 65,000 PTAs. If you're going to hire a nurse practitioner, a good idea to find out, what does their scope allow? Do they have full practice, reduced practice, restricted practice? Some states, nurse practitioners can put a shingle out in front of their office and see patients right off the street without medical involvement. Most need a collaborative MD. When you're talking to a nurse practitioner about bringing them in as part of your integrated practice, let them know right up front, hey, you're going to be responsible for evaluating, planning, directing, administrating treatments. You're going to be responsible for coordinating, delegating, and supervising responsibilities to supportive staff. You're going to need to communicate and assist us in resolving problems. You're going to participate in training. You're going to read our office billing and coding policy and procedure manual, and you're going to sign a form that you're going to attest to follow our billing and coding policies and procedures. You're going to sign a form that you understand all of this, and you're going to need to know the clinical rationale for doing knee injections. You know, you're going to have some nurse practitioners that are wonderful people come into your office, and you're ready to hire them. This nurse practitioner may have never ever injected any type of gel or visco or PRP into a patient. They may feel confident. They may go, oh, no problem. I wouldn't want to be the patient. I wouldn't want to be their first patient. So get them trained. Very important. You'll have to prove training. I've seen a few audits, quite a few audits from Medicare on certain services, and they give a list of things they want to see. So they will ask, who's doing the knee injections? What training do they have? How do they know how to do it? There's many, many companies that could train your nurse practitioners how to do knee injections, trigger point injections. Empire Medical Training, Advanced Practice Services are a couple of companies that do it. Now, when you're bringing on a nurse practitioner, just a little bit about in-network, out-of-network. Your nurse practitioner, if they're going to be billing Medicare for knee injections, well, that nurse practitioner needs an MPI number. There's contracting, there's credentialing, there's certifications, there's accreditation. NPI, CAQH, Medicare PTAN. Are you interested in having DME paid by Medicare? Well, that's a different form. That's the 855S form. If anyone's interested in becoming a authorized supplier of DME equipment, let us know. This is something that we used to do years ago. We stopped because it got complicated, but now we figured it out and we're doing it again. So any of you that are interested in becoming an authorized supplier of DME equipment for Medicare Part B patients, let us know. If you're chiro only, it's a little bit more complicated. If your integrated practice is co-owned by a medical professional, at least 5%, many of the items are waived. It's a lot easier to become an authorized DME supplier if you have ownership by medical professionals. If not, you could still do it as a chiropractor. It's just a little bit more complicated and more expensive. So when it comes to your nurse practitioner being in network or out of network, there's pros and cons to being in, pros and cons to being out regarding the fees, services, and forms that need to be filled out. All right, let's move on now to the most common diagnosis codes: knee osteoarthritis. These are some of the ICD-10 codes for osteoarthritis of the knee: right side, left side, bilateral, unilateral, knee pain, knee stiffness, knee sprains, knee strains, right? Sprains relate to the ligaments of the knee, strains relate to the muscles of the knee. And there's different types of diagnosis codes for that. Here we go: knee pain, right side, left side, knee stiffness. These are some of the most common, simple diagnosis codes to use if you're going to be doing knee injections. Of course, you could use pain and symptom codes. We're not big on them, but you could use them. For example, knee pain. Some offices and staff members go, Dr. Kotler, knee pain, that's a diagnosis? Isn't that just a symptom? Well, it's both. If you don't have anything else, then use knee pain. It's nice to have some sort of diagnostic test to back it up. There's sprains and strains. Get comfortable with these. Cervical strain relates to the muscles. There's a nice photo of the muscles of the neck. You should list those muscles. If you're going to be doing injections into the upper trapezius neck, you're going to be doing rehab on the neck, let's say therapeutic exercises, you should list the muscles that are weak. Sprains and strains in the lumbar region, sacroiliac sprain. There should be laterality with this. I don't get it. There's two SI joints, but if the sacroiliac sprain is on the right side, left side, or both sides, it's the same code. That doesn't make sense to me, but here's one of those things. I know many of you that have been to my past webinars and seminars, I always say this, SMH, I'm shaking my head. I don't understand these rules, but it's not my job. I just need to explain them. I don't make them, I explain them. So there's one. Here, if you're going to diagnose a patient with sacroiliac sprain, I would strongly recommend that you do some ortho-neuro-chiro tests to support it, like Yeomans and Gainslands, and you palpate the area. Of course, you're going to see patients with disc herniations, disc bulges, disc prolapses, sequestered discs, bulge discs, herniated discs. Yes. With radiculopathy, without radiculopathy. Patient has a C5, C6 herniated disc with radiculopathy, that's M50122. Without radiculopathy, without myelopathy, do you know what myelopathy is? Hopefully all of you do. That's cord compression. So no cord compression, no nerve root compression, but there's a herniated disc at C5, C6. It's a different ICD-10 code. That would be M50.222. Of course, comorbidities, especially with knee problems, if the patient is overweight, is that impacting their knee pain? Maybe, maybe not. If it is, include it. Patient has knee pain, but also numbness and tingling in their calves and into their feet. Maybe there's some diabetic neuropathy going on. Does the patient have that? Then include it. If the patient has diabetic neuropathy and they have neck pain, is there a connection? If not, no need to report it, only if it impacts the condition you're treating. When it comes to ICD-10, there's some things you should be aware of, because we have offices all over the country contacting us saying, we were billing an insurance company and out of the clear blue sky, they denied us. And it could be because of the excludes one and excludes two situation. Now, you've probably heard of CPT code bundling. This is a process that most insurance companies use to deny claims based on the CCI edits. A classic example is an adjustment and manual therapy on the same day. If both of these are performed in the same site, the CCI edits kick in and they bundle the codes. Well, ICD-10 bundling is another process that health plans use to deny claims. Give you an example here. If you use M54.5, that has an excludes one indicator. That's going to be a problem if you build that with M54.41. The whole claim will get denied. If you're getting paid for that, you're lucky. Another example, which would cause a problem, a denial, would be to use M62 muscle disorder codes on the same day with M79 myalgia codes. So you could be billing, all of a sudden, doctors, your CA comes up to you or your billing company comes up to you and says, hey, we're getting denied. We can't figure it out. It could be because of this. Simple solution. All right, now we're going to get into knee injections. There are three types of joint injections, actually. We could start with the small little joints like the fingers and toes. The CPT code for injecting fingers and toes without ultrasound guidance is 20600. If you're going to use ultrasound guidance on a small joint, like the fingers or toes, that's 20604. And then we go to medium-sized joints, like the wrist, elbow, ankle. Is your nurse practitioner going to inject that? Great. Without ultrasound, 20605. With ultrasound to a medium-sized joint, like the wrist, elbow, or ankle, it's 20606. And then we get into large joints like the knee, hip, shoulder, without ultrasound guidance, 20610. Large joint injection with ultrasound guidance is 20611. The CPT code for ultrasound is 76942. Do not bill that separately. Years ago, you could have done that. Those days are over. If you use ultrasound guidance, it's included with these codes. Now, some of you are using fluoroscopy as guidance. Well, that's 77002. That's a separate code that you could use. and it could pay very well. I'm not going to tell you exactly how much these codes pay. If you're a member of Target Coding, obviously we'll tell you exactly how much to bill and code. But in this webinar open setting, I can't tell you. I'll show you a couple of things. Actually, I do have a couple of fees I can show you. Oh, by the way, if you're going to be doing injections and billing Medicare Part B, for example, Novitas, which is the Medicare Part B carrier in Colorado, New Mexico, Oklahoma, Texas, Arkansas, New Jersey, Pennsylvania, Delaware, Maryland, grab a hold of their LCA. They used to be called LCDs. That term may sound familiar to many of you billing managers listening to this. You may have heard the term LCD, which stands for Local Coverage Determination. Say goodbye to those. They're all going away, and they're becoming LCAs. There are already many of them out for knee injections and chiropractic and physical therapy. They're called LCAs. Here's an example. Follow this. Follow this to the letter. That's what we recommend if you're going to be billing Medicare Part B. They explain to you what codes to use, what J codes to use. So for example, if you're going to be using Genvisc for your 3 weekly injections, use J7320. That's a HCPCS code for the viscosupplementation that you're going to be injecting. J7320. There's the arrow right there. Genvisc gives you the doses, 25 milligrams, once weekly, 25 units. If you're going to bill just the right side, you probably want to use just RT, left side LT, both sides 50. Fluoroscopy is separate. Yeah, here's a little bit about the modifiers. Modifier 50 is a bilateral procedure. Unless otherwise identified in the listings, bilateral procedures are performed at the same session, should be identified by adding 50 to the appropriate 5-digit code. Example 20611-50. RT right side, LT left side. This is a Medicare fee schedule. I don't see which state this is from, but you see the fees, 20611. You could use that as your guide. Medicare usually pays a lot less than most regular commercial carriers, so there are the fees for 20611. Here's a sample letter of medical necessity for knee joint injections. I don't know, this might be a little bit too small for you guys to read, but if anybody's interested in getting a copy of this letter of medical necessity for joint injections, just send an email to amy@targetcoding.com. That's AMY@targetcoding.com and say, hey, Amy, can you send me that letter of medical necessity for joint injections? Next, amniotic fluid flow. This has been around a couple of years, but a lot of people are just learning about this now. The company that we like to refer to is called BioLab, and this is amniotic fluid flow. There's no stem cells in there. Or, I don't want to get too technical, but there may be some stem cells in amniotic fluid flow, but it's not considered stem cell. It's a liquid allograft, and it's been approved for use for soft tissue injuries, ligament and tendon sprains, degenerative tissue disorders, pain and inflammation. There's a Q code for BioLab fluid flow, Q4206. Document, document, document. This is the key to getting paid by any insurance company. Chief complaint, duration of symptoms, past medications. Has the patient tried physical therapy? It's not a bad idea to have a patient that comes in with knee osteoarthritis to try some physical therapy at first, maybe a knee brace. And if that fails, then you move into more invasive services like injections. Amniotic fluid flow. Next, PRP, platelet-rich plasma injections. There is a code for it. It's a category 3 code, which means it's a temporary. That's why there's the letter T at the end, 0232T. Most plans do not pay for PRP. Maybe you can get some workers' comp or PI plans to pay. Good idea to write a letter requesting authorization first. Stem cell therapy, stem cell, very controversial topic right now. It was calm for a while, but now there's a lot of stuff going on. Where are you getting your stem cells? Is it legal? Is it not legal? Is the FDA approved it or not? Is it embryonic? Is it tissue specific? Is it from cord blood, amniotic fluid, connective tissue? Even if these stem cells centers were allowed to continue to do it, it's all cash. Insurance doesn't pay for stem cell. Put together a nice cash plan, a self-pay rate that's affordable, but check with your state board, check with the company that you're getting the stem cells from, make sure they're approved. Careful with stem cells. Trigger point injections, very nice. These are local areas of spasm trigger points, typically in the upper back and shoulder areas. It could be in the lower back, but less common. 20553 is the most commonly billed in trigger point injection, at least from the clients I work with. Single or multiple trigger points, 3 or more. If you're just going to inject one tendon, some of my clients are just injecting a tendon, one tendon or one ligament. That's 20550. And let's say you're going to bill Aetna for trigger point injections. Good idea to get their policy on it. Here it is. Next, knee braces and back braces. LO stands for lumbar orthotic, LSO, lumbosacral orthotic, KO, knee orthotic. Now, some of you thinking, orthotics, I thought that was only foot levelers, foot, shoe inserts. No, orthotics could be spinal, knee, shoulder. Orthotics are typically used to immobilize an area. They could be rigid or semi-rigid. Need to demonstrate to the patient how to use the DME equipment. The documentation must relate to the patient's expected functional goals. Have detailed documentation in your records that justifies the code being selected. We have samples of that for you coming up. And there's off the shelf and custom fitted. They're all prefabricated, but they need to have certain modifications. Is it minimal? That's off the shelf. Is it more than minimal? Then it may be classified as custom. If you're a chiropractor looking to become an authorized DME supplier for Medicare patients, one of the items you'll have to complete is to become a certified orthotic fitter. I'm actually taking the course right now. I'm almost done. I'm about to take my test, and I am going to become a certified orthotic fitter. Now, some of you might be saying, Dr. Marty, why are you becoming a certified orthotic fitter? Well, I'll tell you why. Because I want to be able to help my clients go through the course faster. I want them to understand what it takes. Now, if your nurse practitioner is not a certified orthotic fitter, that's okay. According to Medicare, your nurse practitioner doesn't have to become a certified orthotic fitter. But if your nurse practitioner does, then there's going to be more opportunity for the nurse practitioner to understand which patients need it. So that's why I'm taking the course. I want to be able to guide the nurse practitioners with durable medical equipment, clinical evaluations. So yeah, I'm becoming a COF soon. So devices that are prefabricated may or not include a kit. There might be some substantial modification. You don't usually have to get a heat gun and start molding these different types of orthotics, but just correcting the Velcro straps, adjusting the Velcro. It's all about Velcro for many of these items with the knee and the spine and the um, cervical region. It's making those Velcro straps snug and tight. That requires substantial modification. So you might want to get custom fitted braces. So here's an example. of a knee orthotic L18 with joints prefabricated L1852, well, this is off the shelf. L0625, very simple, lumbar orthotic, LO, goes from L1 to L5. It's prefabricated right off the shelf. Oh, then we bump up to an LO627. Now things change. It's also from L1 to L5. It's the same type of brace, but this one also has sagittal control. It has, it needs to be custom fit. It's not off the shelf. L0631, now we're going from T9 all the way down to the sacrococcygeal junction. LO631 is a prefabricated but custom fit with expertise. L0648, excellent brace. A lot of the doctors we're working with now, we're buying those LO648s. It's prefabricated off the shelf, prays pretty well. Now here's a very important item. Contact the carriers you bill and get their DME billing, coding, and documentation policies and guidelines prior to billing. Now there were some audits on spinal orthotics, and this is actually good information. So it's actually basically giving you a heads up. It's like letting you know, hey, these are the problems we found. So maybe you should address these, like insufficient description of the product. You want to have proof of delivery, insufficient documentation to justify the need of the item. Detailed written was not provided. There was insufficient documentation to support the custom orthosis. And some claims were denied because doctor didn't even give in the documentation. Also, if you're going to be purchasing DME equipment, get it from a good quality manufacturer, one that sends their information to a PDAC contractor like Noridian for proof. For example, this company, Don Joy, or is this Aspen? They sent a letter to PDAC and they got their official letter saying, hey, the brace that you're going to be selling to healthcare professionals should be billed with L0631. Get these letters. Any company that you're buying back braces from, do a spot check on them. Ask them for the PDAC letter. All right, we covered a lot of information here. So I want to close by going over a couple of things as it relates to knee injections and trigger point injections and stem cells and amniotic fluid flow and joint injections and all that fun stuff is putting together a policy manual. The main purpose of a billing and coding policy manual is to prevent billing and coding errors. All insurance companies want you to do that. Medicare requires it. You know what's interesting? What I'm finding is many chiropractors, they seem to have a little bit of hesitance becoming a Medicare provider to bill Medicare for $30 chiropractic adjustments. I get a lot of resistance and pushback from chiropractors about billing Medicare for $30 adjustments, but when a chiropractor hears that Medicare will pay $2,000 for a knee injection, all of a sudden the chiropractor is interested in doing it. It's just an interesting concept I'm finding. Many chiropractors that I've worked for years, they refuse to become Medicare providers to bill for adjustments, but they're doing hundreds of thousands of dollars per month billing Medicare for knee injections and DME. It's just just an interesting concept. But back to a billing and coding policy manual. If any of you are billing Medicare Part B for anything, chiropractic, physical therapy, injections, you're required to have a billing and coding policy manual. And it should consist of different policies like record reviews, staff training, background checks. You're required to do background checks. Do you? I hope so. Do you keep a list of all the doctors that you're doing your back and staff members? You could have a very lovely, wonderful, innocent front desk receptionist who's taking money over the counter from Medicare Part B patients or entering CPT codes into your computer. That simple, innocent front desk assistant needs to be run through the exclusions list, the Medicare OIG exclusions list. If you wanted to hire this chiropractor, look, this chiropractor is excluded. This chiropractor did not pay his or her student loan, kicked out of the Medicare program. This doctor kicked out of the Medicare program, license suspended. Some of you have your chiropractic practice, and now you've opened up a separate medical practice to do knee injections and joint injections and PRP and laser and all that DME and all that fun stuff. So now you're going to be referring your chiropractic patients to another facility that you have ownership in, but they're not doing chiropractic, it's medical services. I'm not a lawyer, but you should be aware of the Stark Law, which prohibits a chiropractor, medical doctor, osteopath from referring patients to an entity which you have financial interest in for certain services. Not everything. If you and your uncle opened up a sporting goods store and you're selling golf equipment, you could refer your chiropractic patients to a sporting goods store that you own. There's no Stark Law violation with that. But if you own a physical therapy center, lab work, occupational radiology, DME, home health, check with a lawyer to see if it's okay. Anti-kickback statute. Again, I'm not a lawyer. This is a law. Check with your lawyer. It's not okay to pay for patients. Waiving copays and coinsurance could be a violation of the anti-kickback statute. I think I have that coming up. Do you have a policy? Do you offer free exams or any type of free services? Put a policy on it, put it in your manual. You don't want to run into a problem like this. This doctor had to pay $80,000 fine for not, well, what this doctor was doing was he was giving away free stim to his Medicare patients. Medicare looked at it as an inducement. That's a violation. It violates the anti-kickback statutes and in turn violates the false claim. $80,000 fine. How did Medicare find out? How did the U.S. Attorney's Office in Iowa find out? It was a key tam, a whistleblower. Maybe it was a disgruntled employee. Maybe it was a unhappy patient. Maybe it was a chiropractor down the road for some reason. Somebody turned this guy in. Do you have a policy on discounts? Hey, my normal fee is 100, but Mrs. Jones, it's only $40 for you. Is that okay in your state? What about copays, coinsurance, deductibles? Is it okay to waive copays, coinsurance, deductibles? The answer is maybe. Depends on the situation. There are a few situations that we've gone over with our members. By the way, members listening to this, you're going to get the recording. I see a few people already sending in questions. Hey, could I get the recording? Could I get the recording? If you're a member of Target Coding, you will get the recording. Non-members, sorry, this is only, the recording is for members only. This live webinar is open to the whole profession, and wow, do we have a lot of people on it. But the recording, sorry, members only. So there is something called the patient inducement statute, and part of it says if you waive the coinsurance or deductible, you could be violating this statute, and you could be subject to fines and penalties and even loss of your license. So you want to read EOBs properly to prevent errors. You know, office managers, you should be looking at these EOBs very carefully. One of the biggest complaints I hear from my clients is my staff doesn't seem to care. They think, oh, this claim didn't get paid, so just write it off. I don't understand. Why would my billing manager write off a claim without checking with me? Why do I have all these write-offs? Why am I seeing more patients, but I'm making less money? You know, these are the complaints we get from our clients. Office managers, billing companies, read these EOBs. There's many different columns: the billed amount, the allowed amount, the deductible, the copay, the coinsurance, the write-offs, and then finally, what was the doctor paid? Prevention is the key. All right, so we're going to open it up to questions and answers in a couple of minutes. But you know what I want to do right now? We have a sponsor for today's webinar. His name is Brian Koslow. Brian, are you there?
I am here. Can you hear me okay?
Yes. Do you see the your slide up on
I
the
do.
screen?
I do.
Good.
How exciting. I even see a picture of myself. I wish I looked that good.
Yes. So everyone, this is Brian Koslow. He's the sponsor for today's webinar. He's going to talk to you about a few of the things he offers. He's not new to the profession. Some of you might be going, what? That's Brian Koslow? I remember him from 10, 15 years ago. Yes, he has not left us. He's working with many of our clients, and I'm just going to let him take over a few minutes and let him give you an update on what he's doing and what he's offering. Brian, the presentation is all yours. Go right ahead.
Thanks, Dr. Marty. I appreciate it very much. So, for those of you who know who I am, hello again. And for those of you who don't, I'll give you a brief snippet of a history. I married a chiropractor, was married to her for 27 years. We own multiple practices. I built a little company called Breakthrough Coaching, and I sold that to Dr. Mark Santa, who was a client of mine at the time. And since then, I've owned medical practices, chiropractic practices, physical therapy practices. I own also All Care Consultants, which is a company that provides you guys with chiropractors, associates, coverage doctors for disability or maintenance, or if you go on vacation, or maybe you just want to open another office a couple of days a week, you can have coverage. We provide that to you. And we have 77 or 78 chiropractors on our payroll, and then we also have medical doctors, medical directors, interventional pain doctors, just anything like that you might need. But two things I want to talk to you about briefly today. And you have my phone number up on the screen. That's my cell number. You can call me anytime. I'm one of these 24/7 crazy people. But the EMC services, that's for Florida doctors only. So if you're not from Florida, just bear with us for this 2-minute, sort of, I guess, commercial about it. But basically, if you have EMCs that you need for your personal injury cases, the best way to get those done is probably through telemedicine. And this company, My EMC Doc, what they do is they do it through HIPAA compliant portal, and it's done by primarily done by a nurse who's also a chiropractor, and he no longer practices chiropractic, and he does the telemedicine services all day long. And it's no cost to you. They build a PIP insurance, and it's also bilingual if needed. So it's really great. Low cost to PIP. It's I think a couple of $100, and they do the whole consultation. You get the determination the same day, and you have their phone number right on your screen. Just give them a call. The gal's name there is Melanie. She'll get you scheduled to take care of your patients. She'll do all the paperwork. Get it off your CA and your staff, and just let her do everything. It's fine. You can tell her I said so. But anyway, that's the EMC services. For those of you who are not in Florida, and those of you who are in Florida, that contraption on the right side of your screen is a vertical decompression chair. You heard it right, vertical. So instead of having one of these horizontal tables that everybody pretty much has these days, imagine a patient sitting in that chair and having the seat, which is very comfortable. To get on it, obviously, when the seat is in place, and they get strapped into that seat, almost like a straitjacket. Their feet go in those stirrups over there that are hanging, and then the seat slowly but surely drops down. So obviously what happens is the entire torso, lumbosacral, etc., that entire area and the weight from that entire area opens up all of the disc space. And I mean, I've seen it myself. This chair is available in very few places in Florida, and it's this decompression chair is in, I don't know if you guys know Dr. Hope. He's been around for about 30 years. He's got a spectacular practice in West Palm Beach. He's got 3 of these chairs. And patients travel up to 45 minutes and West Palm Beach is a busy area, and they travel up to 45 minutes just to get on this chair. And I've seen it. It's incredible. The chair opens up the disc space. It does it without the horizontal weight on the spine. So there's no weight on the spine. There's no weight bearing at all except for the pull from the torso and the legs, etc. And then you get the mobility and the motion in there, because as the patient's on the stirrups, that entire chair moves. It goes 360 degrees. Obviously, you're not going to move a patient 360 degrees, but as you approach the 90 degrees or the patient's resistance, you can go the other way. So you really get a lot of motion on it. And it also does cervical as well. It's just really an incredible chair. So Dr. Hope uses it, and you can call me about it if you like, but Dr. Hope uses it also as a marketing tool. Orthopedists, who you probably don't get very many patients from right now, are happy to refer to you their pre-surgical cases. And you may not know this fact, but orthopedists have patients coming to them all the time for orthopedic consults, and 60 or 65% of those patients do not get the surgeries because the orthopedic surgeon has to read the riot act to them and let them know that they may have a scar, let them know that it may not work, let them know that there may be pain, let them know that they may be out of work for a week or two recovering. So there's a lot of reasons why a patient may get apprehensive or may already be apprehensive and not want to get the surgery. It may not work. A lot of those surgeries don't work. So some patients get them, of course, and that's maybe 30 or 35% of them. So what happens to the other 60 or 65% of these patients? Well, they may not go to your office, but we have a way now to get them to your office by the orthopedist basically educating the patient, saying, look, I understand you're not going for the surgery. There is this one stop I would recommend you take to see if this will work for you. And Dr. Hope teaches the orthopedist what to say and transfer the patient back to him. So the patient now comes to the chiropractor and gets the treatment on this chair. And about 50% of the time, they get phenomenal results and they no longer need the surgery. But what happens the other 50% of the time is Dr. Hope sends them back to the orthopedic surgeon, letting them know that we've tried everything and I've spoken to the patient and they want to reconsider and meet with you and consult with you. And so the orthopedist wins because out of the 65% of the patients that don't get surgery, he gets a third of them back, or whatever that number is. It's more than he has now. So it's great for the orthopedic surgeon. It's phenomenal for the patient. And of course, it's great for you as the chiropractor because you're providing a result that you can't otherwise get, or probably not otherwise get. It's pretty strong. So that, and you have in Florida the EMCs, and of course, if we can help you with staffing, medical doctors, nurses, or chiropractors, we're at your service. You have my phone number. It's my personal cell. Call me anytime. I'm happy to help you guys. Love chiropractic from above, down, inside out. Marty, over to you.
Thank you, Brian. Now, Brian, you also sell fluoroscopy units, correct? And ultrasound
We do.
units for knee injections
We
and
do.
guidance?
Yep, we have an entire equipment division of our company, and we've been doing that for about 15 years. Everything from C-arms to pain reduction equipment to the ANSs, autonomic nervous system equipment, et cetera.
Excellent. Great.
Yep,
Okay. So thank you, Brian. Just a few
you're very welcome.
other closing comments. Besides these webinars, Target Coding, we do many other things. We have products and services, compliance programs, memberships. I have a book that I've written. I don't know how many of you bought this book. It's my best-selling book. It's been top seller for many years. Excellent book. Hopefully it'll be a movie one day. Nah, just kidding. This book is on the best codes to improve reimbursement. Chapter 1 is all about pairing your codes. Like food and wine, you should be pairing your CPT codes with your diagnosis codes. So we have a whole bunch of examples in the book. Therapeutic exercises pairs with a whole bunch of ICD-10 codes like stiffness and pain. And then the second chapter of the book goes through the codes that pay the most visits. For example, lumbar, long-term treatment diagnosis codes, a whole bunch of those, moderate term, and then short-term codes. There's a whole bunch of cheat sheets in the book. You could print them out and put them in every room on extremity problems and headache conditions, SI joint problems. And then the third chapter of the book gives you about 25 of the most common diagnosis codes and the ortho, neuro, chiro, imaging, all the different diagnostic testing tools to justify your codes. So that's our book. What else? We also have memberships. We have 4 levels. Level 1, membership, unlimited Q&A. You could attend all of our webinars. This one happens to be free, but most of our webinars, there is a fee. For $99 a month, you could attend all of our webinars. We do 4 to 6 webinars a month. Most of them are $99. So let's say 4 of them are $99. That's $400 if you were to pay for each one. Well, if you become a member, $99, all of them are included. Plus our CA boot camps. That's level 1. Level 2 is everything I just mentioned, plus you get access to our member-only section of the website where we have over 20 videos. You can get this video that we just went through. You get all of our forms and logs and templates. The playback recordings are included. Level 3, everything that I just mentioned, plus You get a comprehensive review of your SOAP notes, your intake forms, your HIPAA forms, your fee schedules, modifiers, cash plans, EOBs, 1500 forms, one-on-one, unlimited one-on-one trainings with you and your staff. You also get a billing and coding compliance manual. That's included with level 3, a billing and coding compliance manual with policies and procedures customized for your practice. And you also get our book with level 3. Level 4 is our integration membership, DC, MD, PT, ACU, nurse practitioner integration level 4. Let us know if you're interested in any of our memberships. We also do chart audit reviews. You could hire us on an hourly basis if you'd like. We also do credentialing. Here's our compliance program. We have a target coding compliance program. All of these things are mandatory in every chiropractic practice in the country. I would say 90% of you listening to this do not have a formal HIPAA compliance program. But I'm going to make you an offer right now. If any of you think that you have a formal HIPAA compliance program, send me your security risk assessment. That is mandatory. Some people go, yeah, Dr. Kotler, we're HIPAA compliant. We speak quietly. We have the patients fill out our HIPAA form. It's posted on our website. So we're HIPAA compliant, right? No. A full, comprehensive, approved HIPAA compliance program includes one of the most important things. It's step 1. If you decide to go through a HIPAA compliance program with us, step 1 will be to take you through a security risk analysis, which is basically about 40 questions. Where's your computer? Who has access to your computer? Do you access your computer from your cell phone, from your iPad? Do your staff members access their your system from their home? Do you have associate doctors that take their iPads home with them? All of those questions, that's a security risk analysis or assessment. I would say 90% of you listening to this do not have one. If you do, send it to us. You send it to us, we're going to reward you. We'll send you a free book. Let us know. 90% of you don't have one. Get one. You don't have to use us. We just want you to be HIPAA compliant. Let me repeat, you do not have to use our company. Find a good quality company. Hey, billing managers listening to this, office managers, start working on it yourself. It's not that difficult. Try putting it together yourself. If you can't, contact your state association. They may be able to supply you with one. If all else fails, then contact us. There are many companies that could offer this. Toyotas and Hondas are terrific cars. I love them. We don't sell Toyotas, Hondas. We sell Mercedes, BMW, Lexus, Ferraris, and Rolls-Royce. Some of you might be saying, I'm an all-cash practice. Do I need a billing and coding compliance manual? No. Well, I don't see Medicare patients, but I bill regular insurance. Do I need a billing and coding compliance manual? Yes, you do. By the way, we tell our clients, if you're looking to hire a software company, you're looking to hire another consultant, ask for references, ask for testimonials. We have so many of them. CA boot camps, what we did was we took out a whiteboard. Me, Natasha, Brandy, John, Eric, a whole bunch of us got together in a room. We have a whiteboard and we said, everyone call out anything, any possible job description a CA could have. We had about 150 things on the whiteboard, and then we combined it into 4 modules. Module 1, front desk and patient relations. Module 2, billing and collections. Module 3, therapy and back office. Module 4, office manager, compliance officer. Those 4 modules cover every single job description your CA could have. Forms, you could have the best software in the world. You still need some forms, HIPAA forms, ABN forms, questionnaires, review of system forms, consent to treat minor financial policy forms. Plus, there's a whole bunch of fight back letters and letters of medical necessity for back braces, knee braces, orthotics, vibration therapy, taping, sample soap notes. You could order these right on our website. You'll get them emailed to you in Microsoft Word. You can customize them and do whatever you want with them. Billing, yes. Over the past few years, we've had a lot of requests from our clients for us to do billing. Guess what? Target Coding now does billing. Outsource your billing to us. If you're happy, you have a great office manager, and you're doing everything in-house, that to me is ideal. You have a good quality billing manager in-house doing everything there. That's a trusted person. Don't use a billing company. That's our typical recommendation. But that's not so easy to find. You have Sherry, your office manager, who knows everything. She's been with you for 16 years, and she comes up to you and says, I quit, or I'm leaving. And now what? You don't know what to do. A lot of doctors are held hostage by their staff. I don't know, is it good or bad? If you have a lot of turnover on staff, you should consider outsourcing your billing. Contact us. Some offices we charge a flat fee. Some we start at 6%. Contact us. We'll do a Zoom call. We'll see if you're a good candidate for our billing services. How about credentialing? Does anybody need a PTAN number? Anybody bringing on an associate doctor? I could tell you very few of my clients complain that they have a lack of new patients. I don't know what's going on. Maybe it's COVID related, but just about every doctor we work with has a packed office. Just about every doctor we work with says, Marty, we have more new patients than ever before, but we're not making any money. That's what they say. We're packed, we're busy, but we're not making any money. So if you're packed and busy and you need to bring on an associate chiropractor to see your Medicare patients or your ASH or your Optum patients, maybe you want to outsource the credentialing to us. We'll get you your PTAN numbers in a couple of weeks. We'll have your PTAN number. Our webinars, most of our webinars are approved for CEUs. Our seminars coming up soon. We're starting to do seminars again, post-COVID, live seminars. They're all going to be approved for CEUs. Most of them, not all. Please check with all the carriers you bill prior to submitting claims based on this information to ensure that it is compliant. We can't guarantee that this information will guarantee payment from any insurance company or patient. Target Coding is not responsible for any insurance carrier or managed care laws, rules that may change following this presentation, and you know they change all the time. So it's important to do your best to stay on top of these changes by attending seminars, webinars, joining your national and state professional associations. Stay in touch with us. Connect with us on Facebook and Instagram, YouTube. We have over 50 free videos on YouTube. Just go to YouTube, type in Target Coding. You'll see my channel, my Target Coding YouTube channel. Subscribe to it. Tons of great pearls and information. So I want to thank everybody for attending. I'm going to go ahead and take a look at, see what questions have come in. Here's our contact information: email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. We have a HIPAA secure website. I'm sorry, fax number. HIPAA secure fax 1-844-831-2347. Want to chat with me? You want to set up a free consultation? Send us an email. We'll send you a little link. You click on my calendar. You pick a day and time that's convenient for you, and we'll chat. We could talk about today's topics. We could talk about anything relating to billing, coding, documentation, Medicare, HIPAA. Free consultation. All right, let's go ahead and take a look and see what questions have come in.